depends which system you're looking at, but obviously...
So there are different ways of doing it. Are they all wrong? And
your
Oregon,
initial claim was your initial claim was that you've seen no evidence of harm whatsoever. That's an incredibly bold claim for an enormous...
I would say no evidence of, I'd say, significant harm.
The idea that we should be able to ask a doctor to help us to die conjures up passionate emotions on both sides. A bill to bring assisted death into law is being examined in the House of Lords as they consider what could bring massive change to our society. I'm joined by two eloquent and forensic thinkers from each side of the argument. The philosopher and columnist Kathleen Stock is the author of Do Not Go Gentle, the case against assisted death. It's out in April. And the neurosurgeon and author Henry Marsh is a long-standing supporter of assisted dying. We won't be scrutinising the bill line by line, but we will look at the ethics and the practicalities of a law that asks doctors to kill. Let me start with an opening question for both of you. Henry Marsh, first of all, why do you think the law needs to change?
Because a small number of people are suffering very greatly despite good palliative care.
And why does that mean the law has to change?
Because at the moment, well, according to the Mental Capacity Act of 2005, we're entitled to refuse further treatment even if it means we're going to die. We're allowed to say, I'm going to die, I want to die, I don't want further treatment. I've never heard anybody disagree with that. But we're not allowed to choose when or how or where we die, which strikes me as slightly contradictory. According to the Suicide Act of 1961, Section 2, aiding and abetting suicide is a criminal offence, but as Lord Denning pointed out, it's rather strange to say it is against the law to help somebody to do something which is not against the law. And this paradox arises, as Sir Stephen Sedley, the eminent High Court judge, has said, because the law does not recognise the difference between coercion and acceding to a well-thought-out request in the face of intractable suffering.
Before I come to you, Kathleen, you have cancer.
I have
Henry
cancer,
Marsh.
yes.
I mean, how are you, first of all?
At the moment, I'm in remission, but I have high-risk advanced prostate cancer, which will probably finish me off sooner or later. I don't die from something else first, but I can talk more about that later. But it's irrelevant to my views about assisted dying.
Kathleen, is the status quo really acceptable? Having heard the opening remarks there from Henry Marsh, does your side of the argument have anything to offer people who are desperate for a release from suffering?
Well, the status quo in terms of healthcare is not acceptable because there isn't enough palliative care. There's nowhere near enough. The hospice movement is on its knees. The funding situation is terrible. So if the aim is, and I believe I share it with Henry, at least up to a point, which is to relieve suffering, then palliative care is a way of relieving suffering. Now, I do understand that not everybody wants only that option. But I certainly think that if the government's aim and if lobbyists' aim is to relieve suffering, the most humane, given the wider social implications, which no doubt we'll get into, way of doing that is to put proper funding into palliative care and not to enable doctors to kill their patients.
And what about the status quo in terms of the law?
The status quo in terms of the law is interesting because actually the first thing Keir Starmer did in 2008 as Director of Public Prosecutions was pretty much decriminalise assisted dying peer-to-peer, as it were. Successive Directors of Public Prosecution since then have said that a small number of cases have passed their desk as it is, and only, I think, 5 have been successfully prosecuted since 2009. So the enormous amount of talk that gets generated about the terrible fear of prosecution, I think, is overblown. Now, whether doctors should be prosecuted is a slightly separate issue, but then that relates to whether this is a medical procedure or not, and I strongly think it is not. It is not very technical. It's not something that we need enormous apparatus of the state and the NHS to get behind. So I think the law has a useful kind of grey area in assisted dying without medics being involved, and I'm personally think that should stay.
Henry?
One of the things I find most baffling about this debate is medicine is all about evidence rather than just opinion and hypothesis. There are so many countries where assisted dying is permitted, and a lot of research has gone into it. And I think most of the arguments raised in this country against it are not borne out by the many countries. And Belgium and Holland have had assisted dying since 2002, Oregon since 1997. There is no evidence that significant harm is coming from it.
I mean, that's a bold claim. I'd be very happy to get into the evidence. I've just written a book about it. In fact, I've looked at Belgium, the Netherlands, Canada, Oregon. They have very different systems.
Yes, there are many ways of doing it.
There's plenty of evidence. I mean, it depends on what you're going to count as harm, obviously, and we may differ about that. But if you're talking about that, we can talk about different sets of stakeholders. We can talk about terminally ill people themselves. The diagnosis of 6 months is extremely vague, and people are going to their death earlier than they should have done in many cases. If we're going to talk about the disabled people, there's clearly going to be effects on them, which we'll get into.
Well, and if we're talking my understanding of the research into disability, into the jurisdictions where assisted dying is allowed, the proportion of people with disabilities who have opted for assisted dying is less than the proportion of disabled people in the population as a whole.
It depends which system you're looking at, but obviously...
So there are different ways of doing it. Are they all wrong? And
your initial claim was that you've seen no evidence of harm whatsoever. That's an incredibly bold claim for an enormous...
I would say no evidence of, I'd say, significant harm.
Well, let's get into specifics. Perhaps Jo could ask some specific questions. This is all a bit vague.
Every time I operated, there was a risk I'd cause harm.
Yes, but we want to reduce the metric. And every time you operated, there was safeguarding as well.
It is. But let's get to the metric of what we might call significant harm. I'll come back to you to ask you whether there is a number that you would hail as perhaps unacceptable. But in your mind, Kathleen, is there really anything as such a perfect system where there wouldn't be cases that people perhaps had taken a decision, because we would never know afterwards, that might have gone on to live a life that they would have been happy with? I mean, there's never going to be that system,
there's no system that's perfect, but there are some that are much better than others. And one of the major problems with most of the systems, including the one proposed for the UK, is that effectively they allow doctors to participate in the deaths of people due to what's known as psychological suffering. So, despite the can I finish? So, despite the stereotype that many people have that we must be talking about people in terrible pain, in fact, most of the time we're not talking about people in terrible pain and there's certainly no mention of that in the UK bill. All that is required in the UK bill is a diagnosis of terminal illness of 6 months, a prognosis of 6 months, and it has to be supposedly irreversible and progressive. So there's no mention of pain there. So generally speaking, psychological suffering, in fact, in the UK bill, as we'll get to, that you can get a doctor to help you for any reason whatsoever. Maybe you're just facing a big tax bill. As long as you have the right diagnosis, you can get it.
Right. Well, all right, Henry. But you have to have a 6-month prognosis of a terminal illness.
That's what I said.
So to use the word psychological is kind of merging it into the...
No. Yes, but you're saying there is really no evidence of harm or mistakes or regret or remorse?
I'd say there's minimal evidence of significant harm.
A minimal being 20%?
When the Canadian government was thinking of changing the law, they commissioned a major study of assisted dying in the Netherlands and said they found no evidence of overt coercion.
I think what we need to also recognise, now, up to a point I can agree with Henry, but obviously I'm going to deplore the outcome because they're not looking. Many of these systems have decided, as all assisted dying systems decide, that death is a good thing. And it's assisting suicide or euthanasia is a good thing. And then once you've framed it as a good thing, vast impersonal systems and bureaucracies start to think, well, these are very highly autonomous people who know exactly what they're doing. They start looking for the best possible scenario and they don't look for the worst. However, even with the lack of evidence and the lack of oversight there has been in these systems, there are still many cases of direct coercion, indirect coercion, faulty diagnosis. But the main thing we need to remember is that in this process, the principal victim, as it were, if there has been malpractice or coercion, is dead.
All right. Well, of course.
So there are not going to be any stories
they're not.
retrospectively about how
Henry,
this went wrong.
hang on, Henry. I want to put a quote to you, something that you have said. Even if a few grannies get bullied into it, isn't that a price? Well, isn't that a price worth paying for all the people who could die with dignity? And maybe there is a price worth paying.
Way of saying we have to balance costs against benefits. We have real people who are dying badly, with great suffering.
But you did say a small number. You started off by saying a small number.
This
seems like an enormous sledgehammer to crack.
But it's real.
Sledgehammer to crack enough about that.
But it's real. It's real suffering.
It's all real.
And to balance against that, I'll make it personal. My prostate cancer may well spread to my spine. I must have operated upon hundreds of old men who are becoming paralysed from prostate cancer. Surgery only delays paralysis. And if it's a high level, you'll end up completely paralysed from the neck down. And you may well still live for many weeks or months. Now, that may well happen to me. If that happens to me, almost certainly, you cannot be nursed at home. We all want to die at home peacefully with our family around us. That's a fundamental human wish. Could end up in a situation where I'll have to go into a hospice. Sure, hospices aren't bad, but I'd much rather die at home, and I'd like to feel I had the choice in future, but I could decide to die at home rather than have to end my days after several weeks in institutional care.
Well, listening to that is Henry's personal reflections and thoughts about his potential situation. Do you accept that in those instances it makes some people feel as if they can't live or indeed die with their dignity intact?
Of course, I accept that that's how some people feel.
And so shouldn't they have the option to then...
Yeah, but there's a big leap from some... Can you let me finish, Henry? Some people feel a certain way, therefore we should restructure an entire vast healthcare system to accommodate their wishes. We don't have a Deliveroo health service. We all have our personal stories. We all are mortal. We all have or will face significant illness or know people that will. This is such an enormous change to kind of push it through on the basis of heartrending stories which do not take into account the other heartrending stories that, as it were, my side will have about faulty diagnosis, about families who are absolutely not on board with the decision of their family member to take their own life in a healthcare setting, about the fear that this will put into the heart of many people with respect to the NHS. We can't just change the role of doctors this fundamentally, turn them into suicide prevention in the morning, suicide facilitation in the afternoon, and not expect people to affect the fundamental attitude that millions of people have to the NHS.
Is that happening in Belgium, in Holland, in Oregon, in Australia?
It is happening, but we also have the important thing to remember about our health system is that it differs from, for instance, Oregon's health system, which is the one that...
Does that mean there isn't a system, that there couldn't be a system that could be brought in this country?
What do you mean there couldn't be?
Is there any system in your mind that would be?
I'm not against the principle of assisted dying, but I am against its organisation, its systematisation and its delivery through a centralised healthcare system because of all the many, many effects that will have both on the healthcare system, on people in social care and the wider suicide prevention outcome.
So you accept in principle assisted dying?
Yeah, I'm not religiously against the idea of assisted dying. However, I'm against the bureaucratisation of assisted dying.
How would you envisage a system where assisted dying could be practised safely and humanely?
I don't think that any organised, bureaucratised system which delivers death through doctors can be safe and can be sort of made... Could you let me finish my answer?
Delivered by nurses.
I'm sure the audience want to hear a full sentence from me. So I think that the fantasy that we can make this a discrete part of the health service that only a few people will access, for a start, we've got absolutely no idea how it will go because the economic imperative is very strong to bring this in. It will cut waiting lists, and as economic downturns happen, there will be more demand for it. And I can talk about the way that slippery slopes have developed in other countries as well.
On to what they might
cannot keep this discreetly aside from other operations in the health service.
Let me go back to the issue, because the proponents of the bill, Henry, have resisted calls for doctors to ask patients why they want to end their lives. What's wrong with asking why?
Well, no, I agree. I don't agree with that. I think
you don't. You think yes,
I think
because otherwise, how would you make an assessment if there were to be any?
So, what would be the acceptable reasons, according to you, for someone to take their own life with the help of a doctor?
That they're suffering intractably, they're going to die anyway, and they want to bring it to an end. My brother was in that situation 2 weeks ago. He could have been readmitted to hospital. The oncologist offered to do that, which probably would have prolonged his life a bit longer. But he said, no, I'm not going back into hospital. And then you have to also, you need to understand England, the English palliative care system always rates as one of the best in the world. My own view is that the government's recently put 125 million extra quid into hospices, probably because of the debate about assisted dying and the end of life care.
It's going to be a drop in the ocean, Henry.
In countries like Belgium and Holland, palliative care has gone on developing.
Actually, it is
assisted dying.
Well, can I just ask both of you,
actually.
What does a dignified, because dignity is talked about, that word, language is very important when we're talking about this issue and means different things to different people. What does a dignified death mean to you?
I wouldn't use the word dignified. I'm just, as a doctor, I'm concerned to alleviate suffering. And I think, the purpose, the role of medicine is not just the treatment of disease and illness, is also the relief of suffering. There's no question the fact that historically doctors often eased the passing, as the phrase was. It's not something that doctors talked about in public. Freud, King George V, both had lethal injections. That was heard about because they were well-known people.
Well, let me ask Kathleen too. What does it mean in your mind? Dying with dignity.
Dignity, I think, I agree with Henry that it's a word that shouldn't be in this conversation for the following reason. Once you start saying that a dignified death looks a certain way, perhaps it involves, or an undignified death, put it that way, a loss of bodily functions, terrible pain, incontinence, say, then you immediately make a value judgment that extends to people that have all of those things who want to live. So once you start saying, I'm afraid it's a good enough reason to have all these things and be helped to die by a doctor, then you immediately devalue the life of people who want to live, because you've effectively conceded that their lives too are also undignified.
I don't follow that at all.
Well, that has happened in Canada, because you first of all started with assisted dying for terminally ill people, and then quite quickly it moved on to disabled people.
Well,
so there is that.
Yes, there was a criticism of the way the Canadian legislation was drafted.
Yes, and why do you think that happened?
Well, we will come on to sort of extending and broadening whatever system has been brought into place. But in your mind, would you go further than what is on the table at the moment?
No, I wouldn't.
You wouldn't?
I'm totally opposed to assisted dying on psychological criteria, because psychological diagnosis is not like medical diagnosis. And I think that is wrong. Although, having said that, in Switzerland, Belgium and Holland, you can have an assisted death on purely psychological grounds. And it doesn't seem to have caused terrible problems, but I don't support that.
Well, so you agree 20-somethings killing themselves for being mentally ill, then if you don't call that a problem.
But I suppose a lot of people would say, what about the people who haven't been able to and then live
haven't been able to kill themselves because they're mentally ill?
No, haven't been able to kill themselves because there isn't a system in place, and therefore have lived with suffering and pain that they wouldn't have otherwise had to do.
This is an incredibly crude metric to apply to a healthcare situation. There are some people who are suffering tractably. We are at fault. The system is at fault because it hasn't participated in bringing about their deaths. We're talking about giving them lethal drugs. Let's not be euphemistic. It's nihilistic. And in fact, once you start introducing assisted death into healthcare systems, I disagree with the point Henry made earlier. You de-incentivize palliative care provision, social care, because you've got a much cheaper way of dealing with the problem, and that
is society so evolved that it can actually absorb a system
my understanding is there's no clear evidence that palliative care has been reduced or suffered.
Well, you haven't listened to the evidence that's been given to the committee then, because Sarah Cox, who's the president of the Association for Palliative Medicine, said that in jurisdictions where assisted dying had been brought in, although there had been some increase in palliative care provision, it was 3 times less than it had been in other places where there was no assisted dying. Okay, so we're going to have to look. Well, that is, you said data, you said
Henry,
medicine was about evidence.
A final word before we have a...
Well, it's complicated.
All of a sudden
Henry,
it's complicated.
I'd say from what I've understood, and looking at their fellow Belgium, Holland and this country, always score very, very high in Sweden in palliative care provision.
All right, Henry Marsh and Kathleen Stock are with me till 10, and I'm joined by Kathleen Stock and Henry Marsh. I said that we would talk about coercion, the potential for it, or the potential to prevent it. Kathleen, under the proposed law here, people who want an assisted death speak to a doctor about treatment options. Then they sign a declaration in front of a doctor and an independent witness. Then there are assessments by 2 independent clinicians. Then there's a panel of a social worker, lawyer and a psychiatrist. That's a lot of professionals on tap there, trained to spot any coercion, isn't it?
No, of course it isn't. It's a couple of GPs who may have never met this person before in their lives, who've got about an hour, who might be doing it by video link. And by the time they get to the multidisciplinary panel, that is a sort of gentle conversation. There's no interrogation. There's no adversarial aspect to it. They don't have to look at any background records. They don't have to talk to the family. So absolutely no. The coercive control, for instance, and domestic violence are hard enough to spot when you've got lots of access to information, but in this case you absolutely won't have it. So, and can I just also say there's 2 different cases we should be worried about here. Well, several actually. One is where someone is coerced into taking their own life or having a doctor help them, perhaps for financial reasons or whatever the background kind of abusive situation is. There's a different kind of situation where someone's life is just being made so miserable and so hellish by abuse and violence that this, when they get the right sort of diagnosis, this starts to look like an easy way out. And a doctor should not be participating in that either, even if they have the right kind of diagnosis.
Henry, can you respond, though, to the initial setup of
this
panels
isn't
of
somebody
people?
who is going to die, is usually from cancer within 6 months.
Well,
so how many people do you think, I mean, you must have some idea how probable coercion is in this group. People are going to die in 6 months' time anyway.
Why do you think probabilities are relevant here? Because I would have thought the principle was the important thing. You absolutely do not want the state to back death for people for coercive reasons. You don't want doctors to be killing people on coercive grounds. And even if it was only a few grannies, as you once said, surely that would be something to worry about.
Answer if there is enough in the way of guardrails.
Obviously not. But you can't. No system is perfect. You're not going to be able to.
Some are more imperfect than others.
No, you can't. As the various research papers on the possibility of coercion in the jurisdictions which have assisted dying, they always conclude, no, we cannot exclude subtle pressures. I think to draw an analogy between domestic abuse, marital abuse, and child abuse, for instance, with somebody who's who's going to die from cancer within 6 months, is stretching it
terminally ill people
a bit.
are still alive, and they are subject to all the range of possible situations in which anyone alive is, and that includes people who are being pressured by their family to get rid of care home fees. Those are people who are being physically abused within the home. Those are people who are, so you can have a diagnosis.
Hang on,
6
Kathleen.
months is a very long time,
So
in fact, and it's quite a
opposed-
vague diagnosis.
So you're opposed to the Mental Capacity Act then?
Why on earth would I follow that I
Because people
was...
there could easily be coerced to refuse further medical treatment.
Well, let me just
There's
get you.
one-
But can I just
I
get
can answer
Henry?
that if I
Can
get
I
a
get
chance.
Henry's view, though? First of all, on do you think there are enough guardrails?
I think there are too many, personally. I mean, in Spain, more than a third of the patients have died by the time their request is considered. It's an average of 84 days, apparently.
Right.
And I think, I just think coercion is relatively... I suppose there will be some coercion. I don't know how much. It seems unlikely to me, if you're being coerced, will you really not tell people about it?
Well, I mean, if you look at the panel,
you're going to die anyway.
Exactly,
within
Henry.
the next few
Exactly,
months.
you're going to die anyway.
But Kathleen, what about all the people who genuinely want to end their life? They're having no coercion.
We're talking about...
And the no coercion, they've made that decision, and they are entering into that very difficult decision.
I'm sure our listeners understand what safeguarding is. You don't, in safeguarding situations, you don't just say... Well, what's wrong with which ones? Are we talking about the UK ones where you don't even get asked why you want to die? As I just said, the doctors who are assessing you may never have met you before. They don't have the ability to look into any legal records pertaining to your case. All of those things will mean that the doctor is in absolutely no position to tell whether this person genuinely means it. And moreover, let's not be naive about this. We're talking mostly about elderly people. And there is plenty of incentive for people around them, given the financial situation, given how expensive care homes are and so on.
Yes. Let's talk about the financial.
These are people who are going to die within the next few months, so there aren't going to be great care home expenses.
Right. I mean, in terms of that financial
6 months
consideration,
there's a lot of care home expenses. £16,000 per average patient in the last 6 months of their life.
Did talk about one's financial position might be an element in what makes you reach a decision. And there isn't always money to go round, to paraphrase what he said. Does that give you pause for thought, Henry?
No, not particularly.
No.
What about
ultimately, again, you also have to come back to this question of personal choice and autonomy. Sorry,
that's it.
What about the government's own equality impact statement, which suggested that by year 10 there could be up to, I don't know, £56 million worth of unused healthcare. Now, if it really isn't going to save any money, and if it really isn't, they're all going to die anyway within a few months. So where does this unused healthcare expenses come from? It comes from care homes. It comes from social care packages. It's extremely cheap to kill someone off, and it's much more expensive to keep them alive. And so that means that there's kind of an incentive for the state in one sense, but there's also at the micro level incentives for relatives.
Well, let Henry respond to that.
Well, let me ask you, there are many countries where assisted dying has been legal for decades.
So you keep saying.
Yes. Why in these countries is, as far as I know, there is not very much. There's been no attempts that I'm aware of.
I'm not entirely convinced you've looked.
Reverse the
but also, as I've pointed out...
Hang on.
Yes, let
have
Henry
there been attempts to reverse the legislation, other than the problem in Canada, which I could say is a special case?
Have
but
there
in
been
Switzerland,
attempts to reverse
the legislation permitting assisted dying?
Well,
has there been? Why is that?
Has there been an outcry?
It's working, but the societies which allow assisted dying are reasonably happy with it.
Once you pass the Rubicon, it becomes extremely difficult to put the genie back in the bottle, partly because all systems are set up, all systems go, partly because there is an economic imperative, although people don't want to talk about it, and also because quite a short period of time, everybody knows someone who's participated in one of these deaths, and therefore it becomes extremely difficult to talk about. But people don't want to talk about death in the first place.
Or maybe
anyway.
they should. I mean, there are many people
they should
that
talk
think
about
they
death.
should talk about death. But actually, to go to that question of Henry's, I take your point that once you've crossed the Rubicon, perhaps there is no looking back.
Well, they are in Canada.
But I was going to say, but there hasn't been an outcry, as far as I know. There haven't been movements to try and row back on legislation generally in countries where that's happened, has there?
Well, there's a lot of lobbying goes on. Well, how successful it is can't be the judge of whether it's worthwhile to do. But there's been, for instance, I mean, Canada is a good example, and it's quite. I think it's a terrible example of what's happening, but it's quite close to our system. I mean, Switzerland is a completely different system. You would have to sign up to a association like Dignitas, and it's largely kept aside from the main health systems. Canada and UK are much more close. And I think there you can see, for instance, that there are movements from relatives who have lost loved ones incredibly, from their perspective, brutally, because suddenly they're told tomorrow a doctor is going to help your father kill himself. There's also lots of evidence around misdiagnosis, the kind of vagueness of 12 months or 6 months, and how hard it is to predict. There's also things like frailty, chemical sensitivities, Alzheimer's, so there's dementia involved, anorexia. All of these things are starting to be counted as terminal illnesses, and people are getting assisted deaths for them. So there's lots and lots of problems there that we need to look at.
But I mean, in Canada, if I understand it correctly, the criterion is intractable suffering. There's no time limit on it. We don't have a 6-month rule.
Yes, that's
the bill.
About.
So
it started off with a time limit.
It's a false comparison you've made. I mean, presumably the bill in this country is much closer to Oregon, which has had
it is, but I can give you some disanalogies there if you'd like.
Sorry?
I can give you some disanalogies there if you'd like. I mean, Oregon is nothing like our healthcare system. They've got insurance companies doing lots of it. They haven't got a centralised healthcare system. They don't have. The drugs get posted in the post.
It still relies on doctors to decide whether somebody should have an assisted death.
Of course, you can find similarities, but I'm pointing out you can find dissimilarities.
So are you saying the doctors in this country who would be opining on whether somebody should be given an assisted death or not, are they all acting as functionaries for the NHS, saving money?
Well, I mean, they're functionaries of the NHS.
In what way will the financial pressures you mention actually influence doctors when they make clinical decisions?
You could give an example from the past, which was a worrying one. You can look at the Liverpool path.
That was a disaster.
Yes, exactly, and that's what I'm
properly.
going. Yes, it wasn't used properly in a massive bureaucratic system that is collapsing. It wasn't used properly,
Right.
and yes, the worry is that will happen again.
Let me put two different quotes from two different people. One of them, Hugo Rifkind, a colleague of mine here on Times Radio, who wrote very movingly about his mother, Edith, who had multiple sclerosis. And he said, they are the reason their loved ones are stricken and sad. They are the reason bank balances are dwindling. Even in good times, they are the constant complication. Surrounded by people who love them, they will be beseeched constantly not to think in these terms, but they will. Are you moved by that sort of more subtle, if you like, Henry, thoughts about people who have, in this case, parents who have struggled for years and years but are being asked not to by their relatives?
Well, I mean, again, anecdotally, but also from some of the published research, is more often there is pressure from the family not wanting the person to have an assisted death than the other way around.
More often.
Anecdotally,
Anecdotally. I thought you said you dealt in evidence.
No, I know, but I mean, certainly the work I saw published looking at Netherlands, commissioned by the Canadian government, said that they didn't find evidence of coercion other than unable to exclude sort of invisible coercion. And more often there was a family who were resistant to the assisted death.
I don't believe that more often.
That's what I read.
I think, to your point, to Hugo Rifkin's point, I absolutely think that is a crucial one. This is not just a discrete choice that the rest of us will all be able to ignore. We will all have it, and therefore we will all have to defend to ourselves and to our families why we don't take it. And there will be lots of people who feel they should take it, not because they particularly want to, and if it wasn't there, they wouldn't want it. But now they have this choice that will free up money for the children or take caring responsibilities off loved ones and feeling like a burden.
And that choice of theirs is wrong.
It's wrong for the state to kill them on the basis of it. I'm not judging them. I'm judging the state. No, I'm not judging them. I'm judging
the state. The state in the form of individual doctors.
No, the government, the laws that we're discussing. We're not talking about. I think there's a constant temptation in this discussion to go down to the level of like the individual and think that I'm somehow we're talking about their choices. We're talking about what politicians. It's what politicians decide. It's what the state
Kathleen,
decides.
That is quite interesting. Why can't it be about the individual and what the individual wants?
That's not
because
what we're
you're using
about.
Well,
we're talking about the law. We're talking about NHS policies.
But individuals might want that.
Yes, I get
law.
that. But look,
and as individual doctors and social workers and psychiatrists will be making the
saying
decisions.
that it is wrong for the state to put up the apparatus that allows doctors to kill their patients because they feel like a burden. That is absolutely no reflection on the individuals that feel like that, or even on the doctors that carry it out, because once systems are in place, then they will just be following orders. But we stand at a crossroads where we get to decide
let Henry
collectively.
Who's following orders?
I'm talking about, I just made an aside there where I said that I'm not even, if once we get to a situation where we have assisted dying, assuming we get it, then I'm not, you was accusing me of casting moral judgment on people that felt like a burden. I'm saying I'm not even casting on the doctors who carry out their deaths. I'm saying that we have a decision to make collectively now with democratic participation about whether the state, the NHS, the bodies
let's talk about
decides that doctors can do that.
Let's talk about the NHS and about the state or infrastructure. Henry, do you think the NHS will be good at administering assisted deaths?
I don't see why not. I mean, also coming back to this question, I mean, as doctors, one is making life and death decisions frequently. It's not as though And in my career, I often had anguished conversations, more often with families and patients, given the nature of neurosurgery, whether to let somebody die or not, where by treating them they would live and survive. So that sort of decision-making is going on all the time. And the state permits it because, as a doctor, you're allowed to make these decisions. But you don't act as an sort of agent of the state trying to save money. And I don't see why it would be any different with assisted
the influence
death.
isn't more indirect than that because because trusts get incentivized to cut waiting lists, for instance. But anyway, there is a difference between.
Don't talk over each other.
Can I just
too much,
say there is a
difficult.
difference between letting someone die, withdrawing treatment, and actively giving them lethal drugs. And Henry, you do seem to be constantly eliding those two, but it is important. It's the difference between letting someone go and pushing them.
So,
and we're talking about a system that will be pushing them, not just letting them go.
Well, what would you say about so-called terminal sedation, which is standard practice?
I would say that it is not directly aimed at death.
It's not
not
aimed
the provision
at it,
but assisted dying is aimed at it.
It accelerates.
Yes, so we've got a difference there.
It accelerates.
Well, let's go back to whether the NHS is equipped to deal with this if it were to become law. You'll remember that the Health Secretary himself at the time when this was initially discussed, although the government takes a neutral view across the board, said that he wasn't sure that the NHS in its current state, as it was last year, would be able to deal with it. What do you disagree with him, Henry?
I don't know is the answer, because it's a complicated financial question. I see no reason in principle why it shouldn't be able to cope with it, and I think it should cope with it. As I said, the fact they put a lot more money into hospices recently shows an awareness of the problem. If it became obvious if assisted dying was permitted and is going to be reviewed regularly, as it is in Holland, if it was obvious many people were asking for an assisted death because they had inadequate palliative care, I think that would greatly strengthen the case for improving palliative care. If at the moment palliative care is inadequate, and in some areas it is, the fact people are dying badly and suffering doesn't seem to be helping very much.
What do you think in terms of the state of the NHS? Do you think it could, if the law were passed, obviously you are against a system being in place to do this, but do you think it could cope?
Well, it depends what you mean by cope. I mean, do I think that they might be
that
quite
they would
effective
do it well?
at killing
Yes.
people? Yes, I'm sure they'd kill them very well, but that's not what counts as coping. What counts as coping is making sure that there isn't any malpractice, or at least as little as possible, that there isn't coercion, that's eliminated, that people aren't doing it just because they feel like a burden or because they're depressed, they've been chronic, that people haven't been suicidally ideating for years and suddenly they get an opportunity to do it. So that is what I would count as a system that worked. Are we likely to get that in the NHS when waiting lists are enormous, investment is poor, infrastructure's crumbling, staff overstretched? No, we are not.
Right. I mean, a quote here from Sarah McCulloch, mental health community worker for the NHS. Henry, you think we won't package it up as end-of-life care and patient choice while counting the money saved by your convenient demise? Sign the form, kill yourself, protect the NHS.
I don't buy that. I think that's very unlikely. I think it's very unlikely many healthcare workers would be like that. The idea that
they don't consciously set out to be like that, but the
it's
system
unconsciously.
incentivizes
So you know what they're thinking, but they don't.
I'm just being charitable. You seem to be suggesting that the only possibility is that they're sitting there sort of thinking, right, I'm going to bump some people off for money. But that's just not how it works. It works because people are overstretched, tired, responsibilities distributed across many, many different sides of the operation. And before you know it, there are severe injustices happening and they only get picked up quite long afterwards.
But you say they're injustices. Henry is right that these life and death situations, to coin a phrase, are being made by doctors
all the time,
every day,
in the context
of
the NHS Foundational Charter, which is directed towards improving health, there is a difference between withdrawing treatment and actively killing someone.
Well,
we have to. The law recognises it. We have to keep insisting that there is a distinction there.
Henry, you want to respond to that?
Well, I mean, we trust doctors to make the right decisions with patients and their families.
Do we?
Hang on.
Well, I don't think. Well, maybe
if
you
it's
don't.
sincerely held.
Maybe you don't. And of course, if you don't, then it's obviously it's the end of the conversation.
Well, Kathleen,
if you don't trust
I think it's not all or nothing there, is what I would say.
In your book, you raise the prospect of a rogue doctor like Harold Shipman. Wouldn't someone like that be stopped by the number of other professionals who'd be involved in each decision?
Well, you just said that there's only 2, and then there's a multidisciplinary team, and there's no inquest because these deaths are not going to be treated as unnatural. So the normal ways
but there weren't any at the time of the Harold Shipman. What I'm saying is actually you might
and then
be able
after
to...
Shipman, a lot of safeguards were brought in precisely in order to deal with the possibility, the very rare possibility, but still, and a significant one, of someone psychopathic or malfeasant who is in the system, either actively killing where they shouldn't be or encouraging people die where they shouldn't be. And it's very unclear from the UK proposals how we would find this out, given that the numbers of deaths that they're signing off will not be abnormal. It will now be allowed. There will not be inquests automatically. So you've got to remember that we are moving into a completely unprecedented situation. The healthcare system, as we have it, assumes that we are trying to improve health, not destroy it.
Henry, what do you say to that? Would it just change the whole way that life and death decisions are made? Would it become a sort of machinery? Would it become...
As a doctor, no, I don't think that for a moment.
I mean, make the argument to Kathleen to try. I know she's not going to be convinced necessarily.
Sure,
there are bad actors, but why is it worth it?
To relieve the awful suffering for a small number of people is my answer. I have seen some terrible deaths, all doctors have. I know very few doctors, it's my friends, but it's a bit of relief of suffering. It's very hard to watch somebody dying terribly and do nothing about it if they're begging you to kill them. Not that I did it, because you can't. But historically it certainly did happen, and after Harold Shipman it became a lot more difficult. I think it's better if it's regulated and in the open than just left of a discretion of doctors and nurses at the moment, as it is really a decision when to use large fatal doses of opiates.
As we come to the final part of the debate, I wanted to ask both of you, you touched on it actually, Kathleen, just before the break, how profound a change would this law coming into being be on British society?
I think it would be enormous because we don't have... capital punishment here. We generally don't have state-backed killing or state-backed assisted suicide, and we would get it. And this would change social attitudes over time. It might not do it immediately, but it would certainly affect the institutional attitude to suicide prevention, because it's very hard to see how you could have doctors who, as I said earlier, move from in the morning being all about suicide prevention to the afternoon talking about it like it's a good thing. And we would also have the vast interaction of social media, which, again, once you presented death as a good thing, people are going to take that and run with it. So I think it's going to make a big difference there, along with all the other changes that we've talked about.
Do you think it would be equally profound, but in a positive way?
Firstly, I'd say that if you ask for an assisted death when you're dying from cancer, you're not choosing death over life. It's not suicide in that sense. You're going to die anyway. What you're trying to have some choice over is how you die and where you die and when you die. How the many countries that have had assisted dying for many decades, I don't know how you would judge whether there's somehow the social fabric has suffered, whether Belgium and Holland and Switzerland have become lesser countries and societies have suffered because of assisted dying. I don't know what metric you would use. I'm not aware of anybody in these countries thinking that the availability of assisted dying has gravely damaged society.
Just on that, do you think in a way, has it been noticed in a major way at all in those countries that you
I don't know.
Would it be here?
I mean, I'm not aware of it from what I've read. These countries seem to be living fairly happily.
Well, I could give a concrete example because I was at a conference the other day and I was talking about how in Belgium, to a Belgian audience, how 20-something Belgian people with multiple mental illness diagnoses were being euthanized by doctors, and a man stood up and said, well, I'm actually a minister that's partly responsible for that legislation, and look, we don't want our young people jumping in front of trains. So in other words, the suggestion was that it's much neater and cleaner if mentally ill people in Belgium can kill themselves with the help of doctors and not in front of trains. Well, this was a major politician. Yes, but you just said you didn't know what was happening in Belgium, and I've just given you an example.
Don't talk, because we're not talking about people with mental illnesses necessarily.
But I was answering Henry's challenge. I was answering Henry's challenge about what happens in Belgium.
All right, I take your point. But nobody is suggesting introducing assisted dying in this country for psychiatric
Not yet they
diagnosis.
are.
Well, is it inevitable they will? And what's the evidence will be
Is there
inevitable?
a gap between won't happen and inevitable? It is likely, I would say. It has happened in other countries, hasn't
Which
it?
countries?
You keep Belgium,
No.
Netherlands. It's happening in Canada in 2027.
The legislation from Canada, as I've said before, I think, is an outside case. But in Belgium and Holland, the legislation from the start was intractable suffering.
But they didn't
on that, we
necessarily
don't know.
envisage that they would be killing 20-somethings with mental illnesses when they started.
We don't necessarily know. I wanted to ask very briefly about MPs who've made the decision, many of them new MPs in 2024, very difficult decision. I spoke to many of them when I was broadcasting daily, and they were confused, I think, some of them, about whether this was a matter of conscience for them alone or whether they should be representing their constituents, many of whom did want an assisted dying law. Kathleen?
I think that's partly a function of the way this has been done through the private member system, because it is unclear. It was not a manifesto commitment. There has been no democratic participation. So I think that leaves MPs quite unclear about what they're supposed to be doing when they vote for this.
And what did you think, Henry?
Well, I mean, in terms of democratic participation, the opinion polls have always shown a strong majority in favour of a change of the law.
Depends what you ask them.
Well,
Yeah, but it still is a majority, even if you make the
depends what
questions
you
more
ask them.
difficult.
It may, of course, not come to pass. Let's have a listen to the Times' political editor, Stephen Swinford.
At the moment, the bill is effectively facing death by 1,000 amendments in the House of Lords, where peers who have concerns about the bill, which is a private member's bill, remember, this is not sponsored by the government, have tabled 1,000 amendments, which are going through in the House of Lords painstakingly slowly. And supporters of assisted dying are increasingly concerned that they're simply going to run out of time.
What's your reaction to what's going on in the House of Lords?
Well, the House of Lords is not supposed to contradict the House of Commons.
Right.
They're not elected.
Or is it that the arguments just haven't been made strongly or powerfully enough in the House of Commons, and now it's before the House of Lords?
Well, I mean, I'm not a constitutional expert, but my understanding is the House of Lords cannot...
No. So do you feel it's anti-democratic?
Yes, I do.
Kathleen,
the House of Lords is perfectly entitled to overturn a private member's bill that was
although
not
there
in
are
the
accusations,
manifesto.
Kathleen, of course, that it's being talked out.
Well,
there are
of course there
procedural
are.
arguments
Of course there
being
are by
made.
the lobbyists. But I point out that if they had wanted there not to be 1,000 amendments, they should have brought a better bill. The bill was terrible. They also stacked the committee with people in favour so that all these critical amendments just didn't get through. Constantly, they did not get through. So they've been landed with an absolutely appalling bill. And thank God that the House of Lords is looking at it carefully and proposing all these amendments, because it needs it.
Right, they're talking about reforming, yes, the House of Lords. People are saying it is a failure of democracy. Henry, you would subscribe to that?
In general terms, yes.
Right. I mean, is this going to be the last big chance for something like this to be debated and have got us close?
I would have thought so, yeah.
No.
Do you think it'll happen in your
No,
lifetime?
it'll come back, and it should come back under a government-backed bill with a royal commission that precedes it, with proper democratic participation and enough time to look at all the many, many social ramifications of this, none of which was done in this case. But it will come back.
It will. Do you share that confidence, Henry, if it doesn't go through this time?
I'm not sure. I can't predict the future.
But do you agree that the bill perhaps wasn't properly...
I think the bill is very unsatisfactory, but I still think it's better than nothing.
Right. I mean, the system that you have talked about all the way through the debate, the health system, how many people have you spoken to at that sort of individual level who've said to you, Kathleen, I want this. I want a law that will mean I can end real pain and suffering that I have experienced. And what you're talking about is a slightly once removed view at a system rather than the people.
No, I mean, my view, I've talked to lots that want it and I've talked to lots that don't want it. And my view is not removed from the stories of suffering of people who feel like they're a burden, or of relatives who think their relatives were taken too soon. There is plenty of suffering to go around here. And there are plenty of heartwarming, emotive stories. But at the end of the day, you have to step back and use rationality to look at how this is all going to work, and to try and apply some moral judgment that takes into account the needs of various groups of stakeholders, and not just, as Henry keeps saying, a very small number that are insistingly demanding they want this.
In a rational world, which is how medicine should function, you introduce something, you then assess it, see how it works, and change it accordingly.
It's quite high stakes, though, isn't it, to introduce death and as that thing?
Well, but that's the nature of medicine.
What arguments would you have used, do you think, if Parliament had a sort of consultation, a wider consultation beyond Parliament? Henry?
It's all a question of safeguards. I mean, the first point is choice and autonomy, which is one of the so-called 4 pillars of medical ethics. And then it's a question of how well designed the safeguards are and how they'll be applied. It seems to me there are almost too many safeguards of this bill. But it seems highly unlikely to me there'll be major abuse possible with the bill as it's constructed at the moment.
I just think Henry's not living in the kinds of worlds of the people that I've talked to, the professionals that work with poor and vulnerable people in economic dire straits. I mean, there's just a world of different experiences out there, and we have to pay attention to how this will affect them as well as those who are relatively well off and feel very secure in their own decisions.
I don't follow why that's relevant to when you've been told you've got cancer and again
well, because I haven't heard you talking about those people except to say that there is no problem, there's no evidence that they'll suffer, and it's their choice anyway. I mean, that's a rather callous attitude to.
No, I resent that intensely. I think that's a cheap point. If somebody's got cancer and they're going to die in 6 months' time, why is their social class and wealth relevant to this conversation?
Because, for a start, when you keep talking about cancer, but it's not just about cancer.
Well, it's mainly,
but it's also about other things. It's about terminal illness.
What other terminal illnesses are there relevant in this discussion for 6 months?
And on that point, but let's just very briefly, we literally have got about 30 seconds or a minute. On the social class, on economic standing, how important is that? Or is
Henry right? It's extremely important, because people don't just want to die for one reason only. They look at their general circumstances, and if it is that they can't deal with the paperwork that might get them a social care package, or if it is that their living circumstances are absolutely dire, then that will funnel them towards a doctor with some lethal drugs. So people don't just kill themselves for one reason.
My understanding is that's not what happens, certainly in the European countries that assisted.
And so you don't think it should be brought into account at all in terms of...
I didn't directly see the relevance to if you have a 6-month criterion.
Right, thank you. We have run out of time. Thank you both to Kathleen Stock and Henry Marsh for talking to me and our listeners about the assisted dying bill. It is in the House of Lords. We will find out fairly shortly as to whether it will get through, having passed the House of Commons. Thank you both.